Good evening, ladies and gentlemen, and welcome to this continuous medical educational event sponsored by Pfizer. This is our next edition of Circulate, a new era in thrombosis management. It gives me great pleasure to introduce two excellent speakers we have this evening. Our first speaker is Dr. Mohammed Al-Harari. He's a consultant cardiologist at Tawam Hospital in Abu Dhabi, Al Ain. And he'll be talking about NOACs in ACS and post-stenting. Dr. Mohammed, welcome.
Thank you. Hey, Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, I'm really quite happy and pleased and honored to be with you tonight, and thank the organizer for inviting me, and thanks Dr. Weil for your very kind introduction. The task I was given is to talk about stroke prevention in atrial fibrillation in patients with acute coronary syndrome and or coronary stenting. So what I'll try to cover very briefly, the burden of atrial fibrillation, complication of AF, briefly the original NOAC trials in the SPAF, and then we'll talk about a few of the trials that looked into use of NOAC in this context of acute coronary syndrome and or stenting. And then we'll finish off with what the guidelines tells us about how to use this NOAC in stroke prevention in ACS and or BCI. Atrial fibrillation is very common, you know it, you see it all the time. The prevalence is going up and up all the time. Expected 5.6 million in the States by the year 2050 to have atrial fibrillation. In Europe, the number will be reaching 12 million. And 2060, you know it, you see it. Atrial fibrillation is common in all the people. More than 10% above the age of 80 do have atrial fibrillation. You, above the age of 40, you have 25% risk or chance of developing atrial fibrillation in your lifetime. AF is not benign. It's not just an irregular heartbeat. It has complication. It causes clots in the heart that spreads to the body, give you stroke, thromboembolism anywhere in your body. If you have AF, you have 5 times the risk of having a stroke. If you have a stroke from AF, you have actually double the mortality. So stroke from the AF is actually higher risk than stroke from atherosclerosis. Atrial fibrillation carries 3 times the risk of going into developing a heart failure and twice the risk of dying. It's certainly not a benign condition. Now, when you look at somebody with AF, there are three pathways of management. First, and the most important probably, prevention of thromboembolism. Then look at the rate control and the rhythm control, which we're not going to talk about tonight. I'm not going to talk about the use of vitamin K inhibitor because I'm focusing on the use of NOAC or novel direct anticoagulant. As you know, there are 4 well-established NOAC agents: dabigatran, which is antithrombin, rivaroxaban, apixaban, and edoxaban, which are factor Xa inhibitors. Dabigatran excreted predominantly by the kidneys, and the apixaban is only 25% excreted by the kidneys. There were 4 major trials that look into the use of NOAC in non-valvular atrial fibrillation, comparing them with the previously standard treatment of vitamin K inhibitors. The RELY for dabigatran, ROCKET for rivaroxaban, Aristotle for apixaban, and ENGAGE AF for the edoxaban. There were large studies, minimum of 15,000 patients per study. The aim of this study, because we all had warfarin, used warfarin, still use it in a lot of patients even now. It's all problems, fluctuating INR, risk of bleeding, need of monitoring, etc., etc., etc. So what we wanted, an agent that you don't have to monitor, and it shows at least as good as warfarin. So it's non-inferiority was the primary aim of these trials, and really we're looking at the risk of stroke, thromboembolism, and the safety risk of bleeding, and going through the Aristotle, which looked at the use of apixaban versus warfarin. Again, large study, 18,000 patients. Apixaban not only showed non-inferiority, but actually showed superiority compared to warfarin as far as reduction of stroke, whether it's ischemic or hemorrhagic, and also significant reduction in the risk of major bleeding. The dabigatran studied the use of dabigatran versus warfarin in 2 doses, 110 and 150 milligram twice daily. And the 150 milligram showed also significant superiority or being better in reduction of risk of ischemic or unspecified strokes, while the 110 milligram showed non-inferiority. So if you want a better reduction, you get the 150 milligram. The trade-off with the 150 milligram, that there is a higher risk of GI bleeding. The Rocket AF looked into use of rivaroxaban versus warfarin, again, non-valvular AF, again, large trial of more than 14,000 patients. And the rivaroxaban is better in as far as reduction of stroke or systemic emboli, with no significant increase in the major bleeding, except the GI bleeding, which was higher in the use of rivaroxaban. Edoxaban in the ENGAGE AF trial, against a large trial, more than 20,000 patients, studied 2 doses, the 30 and the 60 milligram versus the warfarin, and both showed a non-inferiority and maybe some superiority with a 60 milligram dose, and the safety as far as reduction of bleeding was obviously best with the smaller dose, 30 milligram, which is what nobody used now practically. So therefore, with this evidence, the guidelines straight away recommended the use of NOAC as instead of vitamin K antagonist in patients with non-valvular AF, obviously except the people with obviously mechanical valve, moderate to severe aortic stenosis. Otherwise, NOAC is the preferred agent. And even those already established on warfarin, if they have a TTR time therapeutic ratio less than 70%, and most of the patients are, then we must move them to NOAC. So then came the issue of anticoagulation post-ACS or BCI. So you have 2 conditions here. So the atrial fibrillation, for which that we know we have to take a long-term anticoagulant, preferably NOAC. And then somebody had a ACS, particularly who had stents, even elective stents, that have to be on a year of 2 dual antiplatelet. So if somebody has the 2 conditions, what's the best strategy? You have, obviously, if you give too little, you carry the risk of either a thromboembolism from the AF or stent thrombosis if you give less antiplatelets or less. And if you give the 3, then you carry a risk of bleeding. So is it dual antithrombotic or triple antithrombotic, and for how long? Now, obviously, as with every condition, you have to individualize the management of the patient according to the patient in front of you. So there are patients who have a higher risk of, either stent thrombosis or thromboembolism. You're diabetic, you're patient with CKD, those who have clear recurrent cardiovascular event, previous stent thrombosis, very complex anatomy, those are higher risk either for stent thrombosis or stroke. Those with high risk of bleeding, also we know you're hypertensive, those with, again, bad kidneys, bad livers, previous stroke, if they are on warfarin, labine, INR, history of bleeding before, concomitant drug use, etc., etc. So the strategy to reduce your risk of bleeding should really go to the basic. So use radial artery for access, use PPI in both, and those who actually have risk of GI bleeding. Don't use heparin if somebody already on warfarin, INR is really high. Don't preload with dual antiplatelet, particularly B2, Y12, those who are non-STEMI, and better to defer until you know the anatomy during coronary angiography. That does not apply to STEMI. Don't use glycoprotein 2B3A routinely, just on selected patient bailout or procedure complication. And the other issue, can we give a shorter duration of this antithrombotic or antiplatelet therapy, which has been looked into over the last decade with several trials, some pre-NOAC, some through the NOAC, and with parallel to them, we had several guidelines culminating the 2019 AC cardiology guidelines in atrial fibrillation, and the very more recent guidelines on acute coronary syndrome. So even in the pre-NOAC area, people were thinking even before the NOAC, can we reduce the duration of this otherwise triple therapy of vitamin K antagonist, B2, Y12 plus aspirin, duration from 12 months? Can we do something about it? And one of the first trials, these guys are triple therapy, and basically they looked into, actually they continued the aspirin for the year plus the warfarin, but they looked into reducing the duration of the B2 Y12, which was the predominantly clopidogrel, to 6 weeks rather than 6 months. And actually, they found actually there's no increase in cardiovascular events or MI, and there was no difference even in the bleed. And there was the what they call the WAS trial, again in the era of warfarin. What they did in this trial is actually they stopped the aspirin. So immediately after the procedure, kept the patient on warfarin and the B2Y12, which was clopidogrel. And what they found, there was a significant reduction in the risk of bleeding when they did not give the aspirin, without increased risk of thrombotic events, MI or resting signal elevation. In the NOAC area, we had a few trials involving all the 4 agents on NOAC. The Pioneer has looked into the use of rivaroxaban dual therapy and triple therapy versus vitamin K antagonist, warfarin, and by that, the trial had 3 arms against a big study, 2,000 patients. And one arm was rivaroxaban at a reduced dose, not the standard 20 milligram dose, 15 milligram plus clopidogrel. And the other arm, they gave clopidogrel, aspirin, plus very small dose of rivaroxaban, 2.5, versus the standard before or then of warfarin plus clopidogrel plus aspirin. And the trial was for the 12 months, so it was not shorter duration. And what they found that the rivaroxaban-based regime has significantly lower risk of bleeding than the warfarin, whether it is the triple or the dual regime for the rivaroxaban. And there was no significant change or increase in the stroke or cardiovascular death or MI. So rivaroxaban-based regime with the dual or triple was safer as far as the bleeding, without increase in the event, cardiovascular event, MI or stroke. Then we had the dabigatran looked into and the dual PCI. Now here they just looked at the use of dabigatran plus B2Y12 without the aspirin versus warfarin, aspirin, and clopidogrel for 12 months. Again, a large study of 3,000 patients. And what they found, again, the dabigatran-based regime, particularly the 110 milligram, has a much lower risk of bleeding compared to the triple and vitamin K, B2, Y12, and aspirin regime, and with no significant increase in the thromboembolic events, MI or stroke. The third agent was studied is the edoxaban in the INTRUST trial. Again, very similar design to the dabigatran trial, where they compared edoxaban at the 60 milligram plus clopidogrel without the aspirin versus the triple therapy, again for 12 months. Similar finding, significant reduction in the risk of bleeding, and no increase in ischemic events. So dual therapy with vitamin K and with the NOAC in the form of dabigatran, rivaroxaban, or edoxaban is actually safer as far as reduction bleeding, with no increase in cardiovascular, with no ischemic events or MI. Then we had the Augustus trial, which is really the largest because it had 4,614 patients in 30 countries. And this trial was 2x2 factorial trial. So all the patients were on B2Y12, mostly clopidogrel, all of them. And then when we randomized to either Bexaban or warfarin. And then further down, they were randomized to aspirin or no aspirin. So the patient will be either on clopidogrel, Bexaban, aspirin, clopidogrel, Bexaban, no aspirin, or clopidogrel, warfarin, aspirin, clopidogrel, warfarin, but no aspirin. So 4 arms. And the study was for duration of 6 months. And basically, the study showed that all the Bexaban-based regime had significantly risk of bleeding, 31% relative risk reduction of major bleeding. And while the use of aspirin, so adding aspirin to the either regime, the warfarin or the Bexaban, actually was associated with double the risk of bleeding. So being on the triple therapy, including the aspirin, have a high risk of bleeding. On the double or the Bexaban-based, actually have a lower risk of bleeding. And the Bexaban arm, there was 17% reduction in the risk of hospitalization or death combination, driven predominantly by the risk reduction of hospitalization. And adding the aspirin, in addition to doubling the risk of bleeding, it did not add any significant effect or benefit as far as death or hospitalization. And in this study, there was a large proportion what were treated medically, i.e. did not have invasive therapy, no stent, nothing. And they also this group has showed similar benefit, i.e. being on the Bexaban-based regime is safer, less risk of bleeding without increase in ischemic or stroke events. So the GOSTs basically give us 31, showed us that Bexaban-based regime give us 31 relative risk reduction of bleeding, 70 relative risk reduction of deaths plus and or hospitalization, but there was no significant change, reduction, or increase in the death or ischemic events. The aspirin-based regime give us twofold increase of bleeding without adding benefit as far as reduction in death or ischemic events. So a Bexaban-based regime with dual therapy seems to be the best as far as safer without increasing the risk of death or ischemic events. This is actually meta-analysis of all these 4 NOAC trials that basically combination include 10,223 patients. And basically, all these studies, actually, I didn't mention at the beginning, they were not powered to show efficacy as far as reduction of stroke or cardiovascular event, but mainly to show safety. And all of them did show safety as far as reduction of bleeding. And overall, there was 2.3% absolute risk reduction of bleeding. There was actually a trade-off of 0.4% increase of stent thrombosis, but this did not translate into any significant difference in all-cause cardiovascular death, stroke, or cardiovascular events. So basically, NOAC-based dual regime, NOAC plus P2Y12, is safer than the warfarin-based triple regime, and without increasing in the stroke or cardiovascular event because of the reduction or taking off the aspirin. So what the guidelines tells us, that the guidelines 2020, the atrial fibrillation guidelines, basically told us that obviously all these patients should be on NOAC all the time, okay? And if your patient has acute coronary syndrome, he has to be on triple therapy for a month. The aspirin, the B2Y12, which is should be clopidogrel, and then after that you continue with B2Y12 for a year, but you can reduce it to 6 months if your patient risk of cardiovascular event is not high and the risk of bleeding is relatively high. Those who are treated medically, remember this, those who are treated medically do not need the triple therapy. So obviously they need the anticoagulant, preferably NOAC, and the single antiplatelet, preferably B2Y12, and which should be clopidogrel. So there is no need for aspirin. And for those, you give them the B2Y12 for only 6 months, although you can increase it to 12 months if you feel the patient risk of whatever stent thrombosis or myocardial infarction is higher. Those who actually were elective, the chronic coronary syndrome patient, again, NOAC all the year, triple therapy for a month, and then B2Y12 for 6 months, although you could either decrease to 3 months or increase to 3 months to 6 months, so to a year. It depends on your patient risk of ischemic events. The more recent acute coronary syndrome guidelines has actually basically mostly reinforced this in the setting of acute coronary syndrome, and basically tells us that at least 1 week of triple therapy is a must. So this class 1 recommendation, at least 1 week. But you should, class 2 recommendation, keep it for 1 month. So which is very similar to the 2019. So 1 month is the preferred, but you can reduce it to 1 week if you got the patient risk of bleeding is higher, and risk of ischemic events or stent thrombosis, myocardial infarction, whatever is low. If you use rivaroxaban and dabigatran, you should use the lower dose than not the standard dose for stroke prevention. So 15 milligram rather than 20 in rivaroxaban, and the 110 milligram of dabigatran rather than the 150. Now, if those who are treated medically, you should use only single antiplatelet and basically skip the aspirin. So you keep them on their anticoagulant, preferably Brady-NOAC, and the B2Y12, preferably clopidogrel. And those who require oral anticoagulant, you may consider stopping the B2Y12 after 6 months. So from 6 months on, you just keep them on the WAC. Again, especially if the risk of bleeding is higher and the risk of MIs, stent thrombosis, etc., is less. Now, what we should not use epetraxole or clopidogrel in this regime because of their high risk of bleeding. So when we talk about B2Y12 in this dual regime or triple regime at the beginning, should always be clopidogrel. So the summary of the ACS guidelines, the diagram here from August of this year, it tells you basically for the default strategy should be a minimum of 1 week of triple antithrombotic, either NOAC and dual antiplatelet, and then 6 months of dual thrombotic, which is the NOAC and the clopidogrel. And ideally, you should keep that for a year, but you may reduce it to 6 months. So this class 2B may reduce it, but ideally, you should give them at least minimum of 1 week triple anticoagulant, and then finish the year of dual antithrombotic, which is the NOAC and the clopidogrel. If your patient has particularly those higher risk of ischemic events from the coronary, then your triple therapy should be for a month, which is what most of us do, and then finish with dual therapy, do your NOAC and your clopidogrel for the rest of the year. And that is it.
Thank you, Dr. Mohammed. We'll have a panel discussion at the end. Please keep your questions till the end. Our next speaker is Dr. Tariq Bakri. He's a consultant physician at Sheikh Khalifa Medical City in Abu Dhabi, and he will be talking about anticoagulation for thromboembolism in cancer. Dr. Tariq.
Thank you, Dr. Wael. Good evening. Just let me share my slide. Okay. So this evening, thank you, Dr. Wael, and thank you for the organizer to invite me to talk about this challenging subject. Basically, anticoagulation, as already mentioned, is something important, but also carry a little bit of risk. And same as in atrial fibrillation, we have to use anticoagulation in VTE And today we'll concentrate a little bit about cancer-associated thrombosis. So my objective for tonight, basically, I need to highlight the importance of thrombosis in cancer, because it's really common complication and also major cause of morbidity and mortality. We have to recognize cancer per se has increased risk of thrombosis and VTE, but we have to recognize the highest risk factor, which will help us sometimes in prophylaxis and also in the treatment, and also guide us for the duration and type of treatment. And we will review the recent guidelines, which really doing some switching the last few years, where it was more like low molecular weight heparin, and nowadays DUAC or NOAC, whatever we're going to call it, it doesn't matter. Basically now it's coming as a standard of care, especially for non-high risk cancer patients. So we know that VTE, even without cancer, carry high significant morbidity and mortality, still one of the leading cause of death. A patient with high risk, they might develop DVT or PE or both. And we know that PE can be fatal. And it's the third most common death in cardiovascular disease after heart attack and stroke. If the patient survive PE, then might go into a chronic complication, which is post-thrombotic syndrome or CTIF, and both of them, they have really reduced quality of life. Why VT is important in cancer in particular also, because in this study showed that VTE is the second cause of death after cancer progression, equal to infection. And also when the patient with cancer get hospitalized, one of the most common cause of death for those patients is PE. So in the next few slides, I will really go through some facts and to mention the burden of the cancer-associated thrombosis, and go through some natural history of cancer and VTE risk, because it goes up and down through the journey of the patient with cancer. So as we already mentioned, thrombosis or VTE is very common complication. About 15 patients of cancer, they develop symptomatic VTE. But also, if you see, it's very important to keep VTE on thrombosis in mind, because up to 50% in cancer, they don't have symptoms, and they carry the same risk for death and complication. So this is one of the also take-home message from this presentation, that if any patient with cancer present with vague symptoms, vague abdominal pain, vague symptoms and signs, consider VTE as one of your diagnoses and try to rule it out. So the common one will be DVT and PE, but those patients also might have intra-abdominal thrombosis, splenic thrombosis, portal vein, hepatic, and so on. And we know also that VTE can be the presenting sign of occult malignancy. So 10% of idiopathic VTE develop cancer within 2 years. That doesn't mean every patient who has VTE need to have a full body scan, CT, but we need to educate our patient about the possibility, and to have a close follow-up and give them, tell them to tell us if there is any weight loss or any other symptoms, alarming symptoms. But if the patient initially develop or comes with recurrent idiopathic VTE, or the patient comes with bilateral DVT, very high suspicion from the history and physical, very strong family history of malignancy, then it might need to be done from the first encounter. So here there are a few concerns and challenges in cancer-associated VTE, which make it very difficult for the treating physician and also for the patient. We know that the patient is handling tough situation with cancer under stress, and they have already poor quality of life. when that patient or she or he develop VTE, that will put more burden on them. So VTE can really affect the patient with cancer in multiple ways: delay of treatment or trigger changing in cancer treatment regimen, which sometimes can affect the survival. And also, if the patient gets hospitalized for VTE, or during hospitalization, the patient will have a prolonged hospitalization, put him at higher risk of recurrent thrombosis and VTE, and also maybe expose him to more risk of infection and more risk for mortality. At the same time, many of our cancer patients go into surgery, which really increase the risk of VTE, and the VTE can compromise the outcome of this surgery. So overall, VTE really put more pressure and more burden on our cancer patient, more than what they have already. So cancer by itself is, as we said, it's really one of the major risk factors for VTE, because the coagulation system is highly activated in patients with cancer. And here are some of the common mechanisms to develop VTE. So it could be venous stasis, damage to the endothelium, expression of a procoagulant protein on the tumor cell surface, activation inflammatory responses, and we know inflammation and VTE really goes hand to hand. So just, you can either drop the answer in the chat box or just try to answer this question. So which factor increase the risk of VTE in patient living with cancer? Age, stage of cancer, type of chemotherapy, race, central line, few of them, all of them. So here, the answer is really all of the above. And I will show you a few things in the next few slides. So here's a journey of a patient with cancer. You can see the dotted line is risk of VTE in general population. The minute we give diagnosis of cancer to our patient, it will increase 4 to 5 folds to develop VTE. And during the journey of the VTE of the cancer patient, the patient will go through multiple phases, which really increase the risk of his VTE. So the patient, if he gets hospitalized, if he gets surgery, initiation of chemotherapy, all of this will increase the risk of VTE and needs to be kept in mind. Even if the patient gets recovery or go into remission, the VTE risk continue for many years before it goes away to normal, if it goes to normal. At the same time, if the patient has really metastases, then the risk of VTE start going up again. So here we can see that there is multiple risk factors to develop VTE in cancer patient. We can divide it into 4 groups. Patient-related, so if the patient has multiple medical comorbidity, if the patient has a prior history of VTE, hereditary risk factor, hypercoagulable state, or presence of varicose vein. On the right side, we can also relate it to tumor in particular. So the site of the cancer is very significant. You can see very high risk in the stomach, pancreas, and brain. High in lung, hematological, gynecological, renal cancer. The stage of the cancer, the degree of the histological grade of the tumor can affect the risk, and also time since the diagnosis of cancer. The other one, it could be related to the treatment per se. So, if the patient go into radiotherapy or surgery, if the patient has blood transfusion, and many of our patients with cancer will need that. Patient might need hormonal therapy, specific other therapies. Again, hospitalization, central venous catheter, most of our patients will need it. So this will all put the patient at higher risk of thrombosis in cancer. And the last one, we can say through the biomarkers, few of them, but the one I put in red is the most common one, the D-dimer, the P-selectin, and the MD tissue factor activity. And you can see here, some of those we already talked about as a risk. It's already found in the corona model for outpatient to estimate the risk of VTE in some patient, to see if we can do prophylaxis for them. So you can see the site of cancer is important. Pre-chemotherapy platelet count above 3,350, hemoglobin less than 10, patient on erythropoietin therapy, chemotherapy leukocyte above 11, of course, BMI. So those are very important to sometimes to calculate, to help us to decide which patient really needs to be sometimes with prophylaxis other than just treatment. So here it will give you an idea. As we said, it's very important with the time after we give the diagnosis of cancer. You can see the highest risk is in the first 3 months, then start going slowly down. But even after 15 years, the risk is still almost similar to somebody without cancer. Age is very important, and gender. You can see here that the risk much higher in the elderly population. Initially, male little bit on the higher risk for the developing VTE, but around age of 70, females start having a little bit more risk. But you can see overall the risk increase with increase of age. Recurrence of VTE is also common in VTE despite the treatment, and you can see that the peak recurrence is usually in the first 6 months, then slightly go lower, but it will last for many years even with the treatment. As we said, already mentioned, the cancer type, you can see here the highest risk for pancreatic cancer, brain, AML, upper GI cancer. Then you have the ovarian cancer, liver, lung, lymphoma. Luckily, the most common cancer, like a breast and prostate, has little bit lower risk of VTE, but still more than somebody without cancer. We already mentioned metastasis is important, and you can see like about a 20-fold risk of VTE increase when the patient has metastasis. Surgery, all surgery will increase the risk of thrombosis and VTE, in particular gastrectomy, pancreectomy, and esophageal resection. But all the surgery increase the risk of VTE. We also mentioned the therapy by itself. Here you can see that most of the patient, whenever in different kind of cancer with different kind of chemotherapy, the risk of VTE increase after initiating the chemotherapy. So to summarize, those are the most common or the highest risk factor which need to be kept in mind, especially when we decide how long we're going to keep the treatment. Although now the guidelines is very clear about extending the anticoagulation while the patient has active cancer or chemotherapy. But before that, all the study was up to 6 months. So elderly patient, pancreatic, brain, upper GI, metastases, the first 3 months, first months after surgery, and specific chemotherapy in particular, and in particular multiple myeloma, where there is a specific guidelines for prophylaxis before the patient get VTE. So anticoagulation in patient with cancer-associated thrombosis is and still a major challenge, although in the last few years, the guidelines made it a little bit easy, as we will see in the next few slides. So why it's challenging? Because even when the patient is treated, the recurrence of VTE is higher with cancer patient with the treatment. The major bleeding is higher. The fatal PE, the fatal bleeding is much higher with patient with cancer comparing with patient without cancer. And they are at very high risk of first time and recurrence. So here you can see that, if the patient has both cancer and thrombosis, then the mortality unfortunately increased very significantly comparing to just cancer or VTE. So that's the reason it's very important to have better primary prevention and also better secondary prevention, meaning the duration and the type of anticoagulation. So as we mentioned, patient with cancer-associated thrombosis, unfortunately, they are at higher risk to have first and recurrent VTE, higher risk for bleeding on anticoagulation, and higher risk of dying. So as usual, we have to really weigh the benefit of risk between a bleeding and recurrence, but the patient preference is very, very crucial. And we have to really tell whatever we're talking about, we have to convey to our patient to decide about what's the best anticoagulation we're going to be used and the duration, because they need to really be in concordance with us so they can have adherence and compliance. So I will finish with the guidelines which really changed over the last few years. I will start with initially till 2015-16, the recommendation for cancer-associated thrombosis was always low molecular weight heparin. And that was based on multiple studies comparing low molecular weight heparin versus VKA. And you can see that it was much more efficacious with less recurrent of VTE with similar major bleed. So that's the reason it was till 2015-16 the preferred way to anticoagulate our cancer patient with thrombosis. I like this article, which really published in 2018. You can see here that what we talked about till that time, the guidelines was preferring low molecular weight heparin, but we know that injection is not the best way for long-term treatment. Initially, compliance might be okay, but with time start going down, and those patients at very high risk for VTE. So that's the reason here, in this article, she mentions that like not a clinic goes by where I don't hear, is there a pill I can take instead of the needle? And the first hope started in 2017 during the American Society of Hematology annual meeting, where people start talking about the possibility of using the DUAC for the treatment of cancer thrombosis. And that was based also on meta-analysis of all those patients who has cancer in the study for VTE, the usual one, but they included, each study of them included some of patients with cancer, active cancer, history of cancer. So total was almost 30,000 patients, and it was found that efficacy, if it's not the same, little bit better, and the major bleeding was comparable. After that, we start having the randomized control trials to compare the DUAC with the low molecular weight heparin directly. So we had 4 studies: the Hokusai VTE cancer with edoxaban, Select D with rivaroxaban, and we have 2 studies, Adam VTE trial and Caravaggio with apixaban. The Hokusai VTE was about 1,050 patients. Select D was about 530. Adams was about 300, and Caravaggio is about like 1,000. And all of them showed promising in the efficacy. Again, if it's not similar to low molecular weight heparin, it was a little bit better, but there was always concern about the major bleed or the clinically relevant bleed, which was a little bit more, but all of them was really coming from the GI side. So because of all of this, and because also of further study, which is in in May 2021, again, they looked at the same issue where they found non-inferiority for recurrent VTE using DUAC with comparing to low molecular weight heparin, and also in this study, no difference in rate of bleeding or death in randomized patient. So this is all made the guidelines change their recommendation. I will go through with the latest one. It started changing from 2018, but now we have more years, and now this is the American Society of Hematology 2021 guidelines. You can see that DUAC is recommended as initial treatment, short-term treatment, and long-term treatment. And in the short-term treatment, which is up to 6 months or more, you can see it's recommended over low molecular weight heparin and over warfarin. And again, here the recommendation is for cancer patient to really go indefinite anticoagulation. For 2022 International Clinical Practice Guideline, again, the same. You can see low molecular weight heparin and DUAC, especially in those patients without a GI or genitourinary cancer. It's a grade 1 for both. And for the recent recommendation from the ACCO 2023, you can see again that DUAC is an option with the low molecular weight heparin with high evidence. And also for the long term, you can see that for those patients without high risk patient, meaning no GI cancer or genitourinary cancer, DUAC is also now recommended as a first line. And for the sake of time, I'm going to go a little bit fast. So here, the NCCN, which many of the oncologists follow, this is in 2020. We can see that edoxaban and apixaban was in category 1, rivaroxaban category 2A. Again, for those patients with non-GI malignancy. And I will mention the Caravaggio study in particular because of this study, there was a little bit change in the 2023 NCCN guidelines. So this patient again compared using apixaban, loading dose and the usual dose comparing to low molecular weight heparin. We can see that a good amount of those patients they had really advanced cancer. They have either symptomatic or non-symptomatic cancer. Most of them, 97%, have active cancer. Also, it has really more, the majority of the common types of cancer we were talking about, and it has about almost 25 to 30% of colorectal and upper GI cancer. And you can see that it was non-inferior, so efficacy-wise, apixaban showed the same efficacy with major bleed comparable to the low molecular weight heparin, and also the same when we looked at the major non-GI bleed, it was the same, and for GI bleed it's the same. So this is the first study where it really showed some hint towards apixaban did not increase the GI bleeding, but of course it was not a pre-specified endpoint. So that's the reason more study needs to be done, but it just gave a little bit hint. And this is where, it was mentioned in the NCCN 2023. I will make it bigger here. So you can see apixaban, edoxaban is category 1, rivaroxaban category 2A, those for the without gastric or gastroesophageal cancer. For gastric and or GI cancer, low molecular weight heparin still category 1, but NOAC can be used, but needs to be explained to the patients that they will have a little bit higher risk of GI bleed. But if the patient insists of not taking injection, definitely can be used. And this is the first time where apixaban mentioned that may be safer than edoxaban or rivaroxaban for patients with gastric or gastric esophageal lesion category 2B. So if I'm going to use really DUAC for patient with GI cancer, And also we can talk about the same as genitourinary, any mucosal cancer. With this study, I feel more confident with apixaban, although you can use all of them. I will finish that. For the duration of treatment. Now the consensus really, if there is no high risk of bleeding, the consensus to really keep using the anticoagulation while the patient has active cancer or treated with on treatment, hormonal or continuous chemotherapy or targeted therapy. Same in the American Society of Hematology, again, recommending indefinite treatment if there is no contraindication. Of course, in some cases, end of life, palliative case, high risk for a bleed, and too much burden of the patient, it's something to talk to the patient and the family. So in some cases, we might elect not to use any anticoagulation. Although now DUAC making it a little bit easy, oral versus injection. I will finish with two more slides. This one was presented recently in the last European Society of Cardiology, where it showed 12 months of anticoagulation. They use edoxaban in this case for distal DVT. It showed better outcomes than shorter period, which was 3 to 6 months. And it showed really better efficacy and comparable risk of bleeding. So basically, we have all the option to use. For apixaban and rivaroxaban can be used initially with loading dose. For apixaban, 10 milligram BID for 7 days and 5 milligram BID. Rivaroxaban, 15 milligram BID for 3 weeks and 20 milligram once a day. Edoxaban and dabigatran, usually we need to use enoxaparin at least for 5 days before. Dabigatran also can be used, but all the guidelines put it as alternative. So, and as we mentioned, apixaban, edoxaban comes as a category 1 in most of the guidelines. And it's very important to mention for VTE, we don't do renal adjustment dosage as like atrial fibrillation. And there is ongoing study regarding apixaban using 2.5 milligram BID after the initial 6 months of treatment, as usually also documented in non-cancer VTE. It's ongoing, expected maybe release in end of 2024. So basically, cancer thrombosis is really complicated in a way, although the guideline made it a little bit easier, but still very important to have MDT, including thrombosis specialist or IM or hospitalist with the oncologist, with the clinical pharmacist to decide about the best anticoagulation for the patient and also the best duration. And definitely we have to really have the clinical pharmacist whenever is available to look at the drug-drug interaction, because sometimes we might prefer one medication over the other, or sometimes do some adjustment with the dosage. Thank you very much.
Thank you very much, Dr. Tariq. Please put in your questions. I don't see any questions yet. Dr. Muhammad, are you on?
Yes, I am.
I'll start with you then, Dr. Muhammad. I know you showed it, but it'd be nice to confirm to our audience. When would you use 1 week of triple therapy and when would you use 1 month?
Okay, I mean, basically, as we said, this depends on the balance of risk of bleeding versus the risk of either thromboembolism or stent thrombosis. So your patients have a lower risk of bleeding and more, and then you should give a minimum of 1 month for the triple therapy. So if your patient has high risk bleeding, which as we mentioned in that slide, that had previous GI bleed, they are bad livers, bad kidneys. They are on warfarin, labile INR, use of other concomitant drugs. So patient had history of bleed before. Then those people I will give the duration for 1 week, and then stop the aspirin and keep the B2Y 12, which should be clopidogrel, not Kegrel or Abracibor. And the rest by default, it should be 1 month.
Yeah, and again, as you showed in the guidelines, Prasugrel and Ticagrelor shouldn't be used in double or triple therapy. You should use clopidogrel. And as you mentioned, also the lower doses of dabigatran and rivaroxaban should be used when you use clopidogrel. There was no mention of edoxaban. Was there any mention of edoxaban in the guidelines with regards to the dose?
No, they didn't specify, but they specified these two to reduce the dose. So the other should be the standard dose. That will be the 60 milligram of edoxaban and 5 milligram BID of edoxaban. Obviously, the edoxaban is as per the Aristotle trial, so you reduce it to 2.5 BID. If you have 2 out of 3, age equal to 80, weight or height creatinine.
Dr. Tariq, when would you prefer to use low molecular weight, and when would you prefer to use a NOAC?
So nowadays, really, we go with the NOAC the majority of the time, but any patient with a mucosal cancer, in particular GI, especially upper GI site, better if the patient accepts the idea of injection, because we really need the compliance and adherence. So usually I will prefer it in the especially upper GI cancer. But if the patient, I tell the patient, if you go with injection and anytime you feel fed up, you're gonna stop the medication, please do not do that unless you talk to me. Then we can talk about the other option with the benefit and risk. So that's basically the GI cancer, usually now the preferred one. The preferred to go the low molecular. Otherwise, NOAC can be given to many patients.
Is there any, besides the data that you showed, that's the ongoing trial that's going on, is there any data to show reduction of NOAC after 6 months?
Not at this time, no. And
Nothing.
Actually, it's not recommended. Most of the, basically, it's not recommended to go to the reduced dose as we do with non-cancer, because cancer patient has high risk of recurrence. So it's not recommended to go to the reduced dose. Hopefully, if the study showed benefit, then we can consider it. But till now, we should not do a reduction of the dose.
We always get this question, Dr. Muhammad and Dr. Tariq. What dose of apixaban should you use for dialysis?
Okay, go ahead, Dr.
Basically, for VTE, there is no study done to support the use of any of NOAC with dialysis. So it's off-label. In that scenario, I prefer to use heparin or like low molecular weight heparin, although again, there is no significant data with creatinine clearance less than 30, but overall weighing the benefit and the risk is better to go with non-NOAC. If we use it off-label, it should be like 5 milligram BID for the apixaban.
I think for the AF, what the important thing to say that in dialysis patient, warfarin does not work. Warfarin increases your risk of bleeding and does not add you any benefit. So your patient will be better off with nothing than being on warfarin, which a lot of our dialysis patients are on. So, and that's really important thing to say. As far as the dose, again, there's no really really robust data on the use of dialysis. There is an FDA recommendation that's a bit controversial of the dose of 5 milligram BID of apixaban, which I use. Some use 2.5 milligram BID. I use 5 milligram twice daily. and I use apixaban preferentially, because we saw it's the lowest, the one that excreted by the kidneys. But again, there's no really clear guidelines. The guidelines seem to avoid this because it has not been studied in these dialysis patients.
Yeah, I think we've been starting to use 5 milligrams BID, unless they have 2 factors, as you mentioned. But if they just have 1 factor, which is the reduced renal function, which is the dialysis, we use 5 milligrams BID, and we have been quite successful with that. Again, it's off-label. The data is ongoing. There is retrospective data and observational data, but no actual data on the use of this. But as you said, the use of warfarin in kidney failure or renal failure hasn't been shown to improve. You actually get more problems with warfarin than was first thought. Do you use NOACs for genitourinary cancer, Dr. Bakri?
Yes, it's the same concept where it's a mucosal cancer, so we have to be careful. But all the study showed more GI cancer than genitourinary. So the guidelines always mention it, but not like as contraindication. So again, basically, we have to talk to the patient, give them all the option, tell them the benefit and the risk. Just because NOAC work in the mucosal cells, they are at higher risk of a bleed from the mucosal cancer, but it can be used.
Dr. Muhammad, you showed this, but just for the audience once again, dual antiplatelet therapy post-ACS after the triple therapy for how long?
Dual?
I think dual means dual meaning Plavix and NOAC, or clopidogrel and NOAC.
For how long?
Yeah.
So dual is by default is 1 year. So once you stop the aspirin after a month or a week, if you have to, then you continue with the clopidogrel plus your NOAC preferably for a year. Again, you can reduce it to 6 months if so for medically treated patients, or for the elective, those who are not high risk of stent thrombosis or MI. But again, there are even data for even longer courses, but by default it's a year.
Excellent. Thank you very much. I don't have any more questions here. One more here. Yeah, this is also a common question. The use of NOACs in LV thrombus.
Actually, there are now recent data that showed, was it, I can't remember which one now, is it rivaroxaban? That it is of use, and I think even the probably not sure about the guide actually, can't remember now, that reflect that. I personally use them. I use NOAC for LV thrombus, particularly those that are deemed to be on long-term anticoagulant because of the recurrence of thrombus or the apical aneurysm, stuff like that. What do you do, Dr. Hamid? Right.
Yeah, it's there are a number of case studies and observational studies using thrombus. Most of our patients usually are stented, so it makes the decision easy to use it because they're already on clopidogrel. So I would prefer using a NOAC with clopidogrel in these patients. If they're not stented, then you can use one or the other. Dr. Bakri, if you have 2 factors with the use of apixaban, do you reduce the apixaban dose to 2.5?
Again, this is always the same question where we're facing it every single day. I think we have to separate the dose of the apixaban for atrial fibrillation from VTE. So No study showed we have to really do the reduction of the dose, 2 out of 3 as atrial fibrillation. So no renal adjustment for the treatment of VTE. Of course, any patient who get creatinine clearance less than 30, the risk of a bleed increase with any anticoagulation. But again, this is very important. When we use DUAC, we should really use the appropriate dose. So no renal adjustment, same for rivaroxaban. All the data came reduction. It was pharma PK study, which is very, very small patients. So again, for VTE, we should really separate the dosing from atrial fibrillation. Very important point. We don't want to do half dose where, like, some people, they believe that giving half dose, less bleeding. Basically, in this scenario, we're not protecting and the patient still at high risk. And this could be also legally liable because we're not fully protecting. So always better to stick with the dose, recommended.
That's very important and very interesting to know. Because we obviously, if we have 2 out of 3 for the atrial fibrillation, we reduce the dose. What about the use of NOACs in mitral regurgitation?
Absolutely no problem.
Yeah, I mean, when they talk about mitral, when they talk about valvular disease, they're meaning mitral stenosis. I think that's been made very clear now in most of the guidelines and studies.
Moderate severe, and some people even specify it has to be rheumatic, but the others that also include TAVR, mitral valve rings repair. These are all the only really contraindications are the mechanical valve and moderate severe mitral stenosis. The rest are not.
Questions or comments?
I've got a comment or question, Dr. Bakri, actually. As
Yes.
I mentioned the warfarin for dialysis patient in our case, forget it. I presume the similar thing applied to warfarin in cancer patient with VTE. What's your comment on that? Use of warfarin.
Basically, warfarin is the least preferred anticoagulation for cancer. So it used to be low molecular, then DUAC, then warfarin. Now DUAC, low molecular, depending on the cancer type. Warfarin is the last one. Again, those patients on dialysis or very low creatinine clearance, very tricky patients, and there is no specific guidelines. So basically, I will always sit with the patient, tell him all the options we have, tell them all the benefit and risk, and the patient really need to be accepting whatever decision we will make. So we might use warfarin for the VTE in dialysis patient. Basically, even with the heparin, low molecular weight heparin, we don't have enough a study for patient less than 30 creatinine clearance. So again, this is a case to case, depending on the patient profile, depending on the patient preference. Very, very difficult patient to take a decision, but at the end, somebody needs to take a decision.
One final question here from the audience. Edoxaban or apixaban for cancer-associated thrombosis?
Both are category 1, as we saw in the guidelines. I think both are excellent one, supported by the guidelines. We have sometimes to look at the drug-drug interaction. So sometimes in some cancer, chemotherapy in particular, maybe edoxaban will be a better choice. In other, apixaban might be a better choice. So again, both are very, very good options, depending on the case and depending on the drug-drug interaction. And of course, the preference of the patient. I mean, we have to always give the patient once a day versus twice a day. If the patient really say twice a day is going to be difficult for me, I have already a lot of things in my mind and a lot of medication, I will go with edoxaban. Or once a day, whatever once a day. So I think this is all part of the discussion education with the patient. with food, without food, once a day versus twice a day, reduce dose in a specific weight reduction and whatever. Those all play roles in the decision.
Very much. Well, with that, I'd like to thank our two speakers for some two elegant talks, and I'd like to thank Pfizer and ICOM for organizing this episode of Circulate, and hope to see you on further episodes of Circulate. And this event was accredited for 1 hour of CNE time. Thank you very much, and good night.
Thank you.
Thank you very much.
Thank you.